Sir, please start.
Good evening, friends. Welcome to the PG Track program of Delhi CSI, the 77th webinar. We are 1 week prior to the national CSI, and today we have a discussion on pulse and cardiovascular examination. We have specially invited our dear friend Dr. Kamal Sharma, who is a great orator, a great guide, and also a great speaker and very knowledgeable person. You would always get something new, something that is very exam focused review. So that is the reason we asked and requested Dr. Kamal on a very short notice, in fact, to talk on pulse, and he very kindly agreed. So along with me on this journey, I have my colleagues, Professor Sumod Korean, Professor of Cardiology at GB Pant, and Professor Girish MP, Professor of Cardiology at GB Pant Hospital, and Dr. Nitish Nayak from All India Institute of Medical Sciences, who is Secretary of Delhi CSI. Also, I thank you all for joining on this journey. It's been a beautiful journey, more than 77 webinars consistently. Every time we have more than 300-400 residents who are joining. In case you wish to have newer topics or any particular thing that you want us to address, please write to us. My phone number, personally, you can message also, is 9810121311. And in case I'm hearing that many of you don't get the link, so we are running various DNDMB groups. In case, again, you have a problem, please message to us. We'll share the link of the group, and you can join and also ask MD residents and your colleagues to join on those groups, so that every resident gets the link to and access to all these lectures. All these lectures are also being regularly posted and updated on the web, on the YouTube channel. They are free download available. You can easily download them, listen them, and re-listen them, cut their pictures, enjoy and learn. It's all academics and only pure academics. That is what this initiative is all about. So without wasting time, I think we invite Dr. Kamal to start this session, and let us enjoy this journey of pulse, which is the essence of life. Dr. Kamal, over.
Good evening, everyone. Thank you, my dear friend, Dr. Mohit. It's always a pleasure being with you, Dr. Girish, Dr. Sumod, Professor Nayak, all of you. And thank you for having me all these times. And I'm going to touch upon pulse examination, which has been, as he mentioned, right from the days of Charak and Shushruta, the Nadi Vaidyas. That's from where this all derives. And then it's come a long way. I'll try to cover modern medicine history, but then there is no history which is left in pulse without having a focus on Nadi Vaidyas of Indian sages, which is so important and such an important aspect of evaluation in cardiovascular exam, despite, reaching up to an extent of arterial cannulation and doing interventions and going transradial. But the radial pulse has still remained the main focus. So we all know that pulse is not the transmission of blood from the LV to the vessel that is being evaluated, but it's the expansion of the arterial wall due to pressure changes. The blood reaches much later, and it's not responsible for the expansion. It's the pressure changes which are transmitted to the conducive nature of the vessels, and that's what the pulse is. So historically, it said the sage Kannada, an ancient Indian physician, alchemist, and philosopher, in his book In Science of Sphygmia, described a variety of pulses, and that's why he's actually preceding Hippocrates to describe it first. So it's the sage Kannada who's responsible for first description, not the Hippocrates, who actually 375 BC described the examination of pulse. So it's scientifically also historically documented that it was an Indian sage who first described the importance of pulse. Even Praxagoras, of course, who was the first physician who was credited in the ancient Greek literature to document examination of pulse. But it was not them, but it was the sage Kannada who was responsible for first description. Herophilus, in 344 BC, he constructed a portable water clock or what is called as clepsydra, which is used for medical rounds in the examination of pulse in patients. And this is an actual picture of the same taken out for the Herophilus' instrument. Continuing with the history, the pulses bispherians, which is so important. Apart the two important pulses that are often asked is pulse, water hammer and bispherians. Even bispherians has a long medical history. Observation of double pulse was done by Galen in 1932, and Muhammad actually was describing the terms of percussion wave and tidal wave in 1872, with Broadbent, who described bispherians in 1900 in context of the aortic valve disease. Bramwell put forward the theory of genesis of abnormal pulse, and Fleming described the mechanism in 1957, which I will update when I discuss pulses BIS variants to the current papers of 2021, how things have moved from what was described as the distal runoffs, etc., and these obstructions not being the current theory. William Harvey attributed the generation of arterial pulse to the contraction of LV and found that the source of the heartbeat was into the right atrium, and the sphygmograph, which was then kymograph and sphygmomanometer, were various instruments. That's how science evolved to actually focus upon arterial pulse and its characteristics to distinguish between various cardiovascular disorder. The pulse represents the expansile impulse, which is produced by the left ventricular ejection and transmitted along the arteries, and hence it reflects the condition of the left ventricle and the response of arterial system to the left ventricular ejection. Pulse wave is transmitted along aorta to periphery at a speed of 5 meters per second, but intraluminal blood travels much slower at 40 to 50 cents per second. The genesis of arterial pulse, when the LV pressure exceeds the aortic pressure, it becomes the driving force for the movement of the blood into the ascending aorta. And that's what the pulses do generate. Intrinsic contractility of the left ventricle, size of it and its shape, and the heart rate are the driving forces, while the impediment, which is the vascular resistance, they are the opposing forces. So in short, these two things will determine how the blood flow would be characteristically be responding in these subgroup of patients. The determinants of arterial impedance hence are resistance, compliance, and inertia, and hence these are responsible for development. The resistance is primarily related to the blood viscosity, geometry of the vasculature, and it opposes flow which is unaffected by changes in the heart rate. So the resistance alone is not the sole factor which is responsible for development of the characteristics of the pulse. The inertia which we get is determined again primarily by the mass of the blood column, which opposes the rate of change of arterial flow, that is the acceleration, and this depends on the heart rate. The normal characteristic of the pulse now is described as a wave which is characterized by a fairly rapid rise in the rounded peak. So these are the various waveforms which are classically described in a pulse wave. You have a percussion wave, tidal wave, dicrotic notch, and the dicrotic wave. The first heart sound is followed by what is the percussion wave, rising with the tidal wave, then the dicrotic notch and the dicrotic wave. The S2 is where the dicrotic notch actually corresponds, and this is the correlation between the heart sounds, and that's how usually you auscultate. Put the stethoscope at the base of the heart and keep the hand or finger or a thumb at the carotid pulse, and then try to delineate what kind of characteristic they are having by differentiating where the pulse waves are falling with the first and the second heart sound. The normal central aortic pulse wave is characterized hence by a rapidly rising and a somewhat rounded peak, with the anacrotic shoulder, which is present on the ascending limb, occurs at the time of peak rate of aortic flow just before the maximal pressure. The less steep descending limb is which is interrupted by the sharp downward deflection, which is called as the incisura, or also reflected as the dicrotic notch with the AV closure. So this is the normal characteristic. So you may be asked firstly to draw a normal pulse wave characteristics. So you'll have a percussion wave, a tidal wave, a dicrotic notch, and a dicrotic wave. This is a classical description of a pulse. So the phases are then divided into the ejected wave and the reflected wave. So what you're finding before the dicrotic notch is your systolic phase. What you find afterwards is the waveform which is coming from the periphery, and hence it represents the waveforms that are reflected from the peripheral vascular resistance. So the arterial pulse wave, which begins with the aortic valve opening and the onset of the LV ejection, the aortic pressure then rises because of the early systolic outflow, and the pressure changes from the force of contraction of the LV stroke volume, which then enters the aorta much faster than the flow is distally. And then the rapid rising portion of the arterial pulse curve is hence termed as the anacrotic, which means the upbeat. So anacrotic limb is what the first part of the limb of the waveform. So after the peak, the aortic pressure then starts declining, and as the LV ejection slows down, the peripheral blood flow still continues, and hence during isovolumic relaxation, you'll have a transient reversal of flow from the central arteries towards the ventricle just prior to the closure of the aortic valve, and which is reflected as the incisura of the descending limb. So later on, the second positive wave, which is attributed to the elastic recoil of the aorta in the large blood vessels and the aortic valve closure, but is partially also caused as its summation not only of the elastic recoil, but of the reflected wave, which are coming from more distal artery. So aortic pressure hence decreases again further down in the diastole because of the runoff from the peripheral circulation. So you have basically the percussion wave, which is the initial systolic pressure wave pulse, which is the incident or begins with the systolic ejection just after the second heart sound, and is the predominant monophasic pulse appreciated at the bedside. The tidal wave is the later systolic portion of the pressure pulse. It's the second smaller peak, which is presumed to reflect the reflected wave from the periphery. It's more of recordable, but not normally palpable, while the diacrotic wave is the wave following the diacrotic notch, roughly corresponding to the timing of the second heart sound, and hence it is a diastolic wave. So this is how, as you go from center to periphery, which is say from the carotids to the femorals, the wave is transmitted peripherally with the initial upstroke becoming steeper, the anacrotic shoulder becoming less apparent, and the incisura is now replaced by a smoother diacrotic notch. So as you can see in the diagram here, you can see that the carotids are, as you go from, this is also sometimes asked in the exam, as to what are the changes in the pulse wave characteristics as you go from the carotid to the femoral. So as you go to the femoral, the notch will become smoother. You'll find it more classical in the brachial radials and the femorals, especially in diacrotic pulse. You'll be able to appreciate it more prominently in the peripheral pulses, while the steep rising, instead of the anacrotic shoulder, it will start becoming less apparent as you go towards the periphery. Now, when you have to evaluate a pulse, it will be evaluated under 10 important headings: rate and rhythm. And then the three features of the outputs, which is force, volume, and tension. A lot of people talk about not discussing tension as a characteristic. So they will club force, volume, and tension into one, what is called as the volume of the pulse, and club all of them three together into what is called as character of the pulse. And that's what we usually end up discussing. The vessel wall, radial delay, symmetry. So you have three important comparisons. You compare bilaterally, you compare upper limb and lower limb, and you compare apex and the peripheral pulse. So you have radiofemoral delay, bilateral symmetry, and apico-radial delay or apico-carotid delay. So the grade of palpability is another important aspect. So is the bruit over the artery to look for peripheral vascular disease and peripheral pulses, apart from the tests of the radial cannulation or procedures like your Barbeau test or reverse Barbeau test or Allen's test, etc. Now, feeling the pulse is also called as trisection of the pulse. You trisect the pulse into three, which the use of three fingers. So this is trisection of the pulse. The radial pulse, you put three fingers. The middle fingers are used, and the palmar surface of the fingers, they overlie the radial, and it encircles the wrist. So you have to use it like this, that you're encircling around rather than being on the front. So the classical method is encircling the wrist. The first, the artery is completely occluded, and then you gradually release the pressure until the maximal feeling of the pulse is perceived. Now remember, the distal most finger, which is used to occlude the pulse so as there is no collateral pulsation through the palmar arch, because there is a palmar arch which can give rise to pulsations from the ulnar artery into the radial artery. So radial palpation would require the distal most finger to occlude the pulse completely, and there is no flow coming from the arch. The middle finger is the one that feels or is used to feel the characteristic of the pulse. And the force that is required by the proximal most finger will represent the systolic pressure. So classical teaching was that what is force of the arterial pulse? The force is the force required by the proximal finger to occlude the pulse. This represents the systolic pressure, because if you have to exceed the systolic pressure so that the pulse is not perceived by the middle finger. So greater the force required, more is the systolic pressure. So force is the force required by the proximal finger to occlude the pulse so that it is not perceived by the middle finger, and it represents systolic blood pressure. Volume is the lift perceived by the middle finger. So how well the middle finger is lifted up, and this would represent your pulse pressure or stroke volume, as they say. So stroke volume is represented by the lift or the volume. Stroke volume is represented by the middle, perceived by the middle finger, and that's the lift. Tension is when you occlude the pulse distally and what amount of force you require to perceive the pulse best. That is the tension, and it was assumed that it represents the diastolic pressure, and that is the continuous tension that is present in the arterial line. If the minimal force is required, because if you apply too much of a pressure in a patient in, say, hypotension in cardiogenic shock, you will end up compressing anterior and posterior wall of the radial artery. Hence, you'll have to feel it lightly and gently. So in a patient of shock, don't try to find out and gouge your fingers deep into the radial artery to find it out. In a shock, the perception has to be best perceived only by touching it lightly. Otherwise, you'll be approximating the anterior and the posterior wall. So once this trisection is done, the ring finger, as I said, transmitted pulses is through the palmar arch. Middle finger perceives the lift. It estimates volume and tension. Index finger estimates the force required to obliterate so that it is not felt by the middle finger, and estimates the force or what is the systolic blood pressure. The carotid is the best pulse to evaluate because it's the closest to the heart, and hence the time delay is only 30 milliseconds, and hence it would correlate with the cardiac activity, whatever is happening at the heart. Hence, carotid is the most important pulse. If you are asked in exam which one pulse you will assess, it will be carotid. Not only one because it is closest to the heart, but there are other lot of things that you can do with the carotid, namely transmission of the murmur, carotid massage, carotid artery stenosis associatedly present, carotid shudder. You can even look at the Oliver sign, which is the tracheal tug that you'll find in aortic aneurysm, and single most important pulse that you would be required to evaluate is carotid. And of course, carotid artery stenosis, atherosclerosis, etc. The method of examination in any pulse would be two important or three important things that one should remember would be how to feel it, where to feel it, against what structure, and to define a point of palpation. Now, point of palpation, remember, would be defined by two lines. So you'll have to find out two lines. The point would be defined by lines of intersection of two important lines that are intersecting at the point that you get. So carotid would be palpated by the line of intersection of being one, the anterior border of sternocleidomastoid, that is one line, and second line is the upper border of the thyroid cartilage. So these two lines where they intersect, that point of intersection is the point of palpation. So that's number one. Number two, against what it is felt. So here it is Cheshire tubercle, or what is called carotid tubercle of the C6 vertebra. So against what it is perceived, and how do you feel it? Whether you perceive it with three finger, which is trisectional pulse at the radial, or by the thumb as you do it in the carotid. So patient's position also, you need to define a tendon or a structure, like in anterior border of the sternocleidomastoid, you would ask the patient to press against the against your hand on the opposite side to make the anterior border prominent, and then try to perceive it. So that's the method of evaluation and evaluating this anterior border of sternocleidomastoid. And then the upper border of thyroid cartilage is a bony structure, the line of intersection. So patient lies with their head on the bed elevated at 30 degree. It may be visible just medial, else the pulse, place the left thumb on the right carotid in the lower third of the neck. As I said, at the point of intersection, you don't palpate both of them together. And remember, be very cautious and gentle. You can actually end up triggering a cardiac, in a patient with sensitive carotid bodies, you can actually induce a syncope in these patients with cardioinhibitory response. So this is how you palpate. Use your left thumb for the right carotid and vice versa, and use tip of the thumb also can be used between the larynx and the internal border of the sternocleidomastoid. The brachial pulsation is perceived used with your thumb again, right thumb for the right arm and left thumb for the left arm, with your fingers cupped around the back of the elbow. This is the technique as shown in the picture. So you have to hold the hand and then press it against the brachioradialis tendon and the tendon of the biceps. Between the two, you'll have to feel on the medial aspect. The line again would be defined by the crease here and the tendon of the biceps. So biceps tendon is one, and the elbow crease is the second line. So two lines where they intersect. That's the point where you palpate, and then you flex and see. It's felt of the elbow just medial to the tendon of biceps, as I said. Femoral artery is best perceived gently 2 centimeter below the inguinal ligament. But again, it's not the inguinal ligament that defines. You'll have to define 2 lines, as I said. So it would be one line would be anterior superior iliac spine and symphysis pubis, and the other would be a midline between the two. So again, you're drawing a line joining the anterior superior iliac spine and symphysis pubis, and the second line is the midline of the same. So intersection of these 2 lines defines a femoral pulse, and will be just below the inguinal ligament, usually 2 centimeter below, and it's perceived by again against what? Against the head of the femur. So you ask the patient to make it prominent. The leg has to be rotated externally, slightly abducted, and laterally extended. So extension, lateral rotation, and abduction. That's the best position even to puncture the femoral artery. So just don't hit up the femoral artery blindly. That's never a procedure. Of course, there are fluoroscopic guidances, which is not the topic today, which is just because I've touched upon it's the inferior border of the head of the neck of the femur. But the rotation of the limb is equally important when you have to palpate and make an arterial puncture. These are the important simple things which can actually prevent your retroperitoneal hematoma or a big groin hematoma, even if you have to go femoral, even in the era of radial for maybe intra-aortic balloon pump, etc. Popliteal pulse is best felt with the knee to be flexed at 40 degrees with the heel resting on the bed. Place your fingers over the lower part of popliteal fossa. Fingers are moved sideways to feel pulsation against the posterior aspect of tibial condyles. Again, here the line would be the crease and the upper end of the tibial condyle, and then it's perceived from the side. Dorsalis pedis on the dorsum of the foot, lateral to the extensor tendons. You ask the patient to extend the great toe, and then mid of the metatarsal. If you cannot feel, explore the dorsum of the foot more laterally, because in 10% it can be extraneous. This is how the dorsalis is palpated, felt just lateral to the extensor hallucis tendon, and the posterior tibial, what is called as pimenta's point. As Dr. Mohit said, that I have to mention one or the other names. So that is called as pimenta's point. That's the point midway between the medial malleolus and the heel. So Achilles heel and the medial malleolus, you draw a line midway of the two. The point is called as pimenta's point. That point is used for palpation of posterior tibial pulsation. So coming back to the points that I was discussing, force, volume, tension, etc. First is the rate. Remember, less than 60, more than 100, very clear cut for defining a tachy and a brady. You may be asked, what are the causes of tachycardia? What are the causes of bradycardia? Physiological, pathological. Again, these are all undergraduate things, but remember, those are the things that you can fumble and mumble in the times of stress in exam, and the list cannot be less than exhaustive, including whatever cardiovascular causes. A good intelligent student would touch upon rheumatic fever as a cause, acute rheumatic fever as a cause, to divert the attention from physiological causes like anemia and thyrotoxicosis. So physiologically, of course, infant children, emotion, exertion, tachyarrhythmias, SVT, VT, high output state, drugs like atropine, nicotine, caffeine, nifedipine, and the list is less than exhaustive for what I've added here. Bradycardia, remember, high vagal tone is athletic heart, as that we know. Sleep, postprandial, or there is one other way of remembering, increased tension, where in the eye, in the brain, in the abdomen. So increase intracranial tension, increase intrabiliary pressure, increase ocular pressure. Ocular is glaucoma, obstructive jaundice, increase intracranial tension, acute inferior wall MI, obstructive mixed edema, sinus syndrome, beta blockers, CCBs like verapamil and diltiazem. Paget sign, which people talk about relative bradycardia, again, just to touch upon, it's found in enteric fever, hemorrhagic fever, lymphocytic choriomeningitis, and in the current era, you can find it in patients with COVID-19. You can have either of the two. You can have a disproportionate tachycardia, and you can have some patients presenting with bradycardia despite fever. So these patients are usually defined as relative in terms of heart rate not rising by more than 10 beats for every 1 degree Celsius rise in temperature above 100 degrees of Fahrenheit. So unless that rises, it's less than that, then you call it relative bradycardia, though the patient may have what is called as tachycardia, fever maybe 104, pulse maybe just 100, and that's again categorized as a relative bradycardia. Regularity and irregularity, rhythm would be defined based on the recurring pattern. You would call it a regularly irregular or irregularly irregular when there is no regularity pattern defined. So very often you may be asked regularly irregular, which can usually be with AV blocks or bigeminies or trigeminies or disorders like that, where there are ectopics coming at trigemini, quadrigemini, where 3 beats and the 1 is dropped, or atrial tachyarrhythmias, AF with fixed blocks or complete heart blocks, variables may be regularly irregular. Irregularly irregular, only 2 causes are there. When there is no ventricular irregularity in a patient with ectopics or atrial rhythms, and very important and commonest cause being atrial fibrillation. Irregular also can be physiological if you can find acceleration in inspiration and slowing down in expiration in patients with sinus arrhythmia. So this may be due to variation in vagal tone in young and in children. You can have non-respiratory sinus arrhythmia in digitalis toxicity. Difference between heart blocks and ectopics rhythm can be found in irregularity, which changes with exertion because of extrasystolia or ectopics. Irregularity doesn't change with exertion, would be patients with heart block. Volume, as I said, is a crude indicator of stroke volumes, while high volumes would represent hence patients with elderly, which can be full bounding characteristic of high output states like anxiety, thyrotoxicosis, anemia, systemic hypertension. Low volume would be conditions where there is hypotension. So high volume is high volume, high force, high tension. Just remember hypertension. Low volume, low tension, you just remember hypotension and just correlate the causes. So you need not just cram around everything. Low volume pulsus parvus, as it is called, is found in low cardiac output, valvular myocardial disease, valvular stenosis, pericardial disease, hypovolemia. So again, the characteristic of pulse you can call 0 when it's absent, 1+ when it is reduced, 2 is what is characterized as normal, and 3+ is large bounding pulse. The normal condition of arterial wall is compressible, elastic feel, but in patients with Mockenberg's degeneration or arteriosclerosis, this may not be present. This is demonstrated by Osler's method, which is also called as Osler's sign, where you compress the brachial vessels with raising the blood pressure cuff above the systolic blood pressure and trying to roll the artery after occluding beyond the systolic pressure. So once the Kortokov sounds have disappeared, if you can still roll the artery, then it would suggest that the patient is having Mockenberg's degeneration of the media, which is what is characteristic of arteriosclerosis, and that is called as Osler's sign, and that's how it's demonstrated. So palpate the radial artery, occlude proximally with index finger, compress it and applying the pressure and roll the artery is the other method if you don't want to inflate the BP cuff. Radiofemoral delay classically is described in coarctation. Sometimes it is also mentioned in patients with aortoarthritis. Remember, it is not the slow transmission which causes radiofemoral delay in coarctation. Instead, the brachiofemoral delay has been described rather than radiofemoral, which is more sensitive for the diagnosis of coarct, as there is already a delay of 15 milliseconds from the brachial to femoral. So as you know, carotid reaches in 30 milliseconds, brachial in 60 milliseconds. For a human brain to perceive 2 separate events, the time delay between 2 events has to be around 40 milliseconds. So even in auscultation or even in palpation, human brain would perceive 2 events as one if the time delay between the 2 is less than 40 milliseconds. So that's why carotid and brachials may appear similar. And while you compare brachial with femoral, again, the difference is only 50 milliseconds. But if you were to do, say, radiofemoral delay, the difference is the other way around. Instead, it's now 80 and 75. And so it just needs to be slightly exemplified. So any further delay would easily be appreciated if there is a brachiofemoral delay. Already 15 milliseconds is there, and now you add another, say, 25 milliseconds. Now it would be appearing as 2 separate events, while radial is coming almost later, slightly later than femoral. So it will have to be delayed much further to be appreciable clinically. So brachiofemoral is better, but in children, you can still use radiofemoral. So unless the delay is more than 20, it would not be appreciable. BP measurement is more sensitive indicator of coarct. A radial or a brachial delay is usually suggestive of obstruction or anomalous innominate or right subclavian on the site of the palpation. Now, this mechanism of radiofemoral is important. It's the percussion wave in femoral that is blunted, and only tidal wave is palpable. So it's the when you are comparing. So what you're palpating is the percussion wave of radial. So you get an exaggerated sense of delay. So rather than the mechanical interference in the pulse by the coarct segment, it's the 2 separate waveforms that you're feeling. At the radials, you are feeling the percussion wave. while in the femoral, the percussion is lost because of the obstruction. Only the tidal wave is felt, and hence this delay between the percussion of the radial and the tidal wave of the femoral is what gives rise to the radiofemoral delay, not the obstruction or the flow by the wave of the waveform by the coax segment. The Allen test is intended to test the patency of ulnar to maintain the circulation if the radial is occluded, and I believe all of you know how to do it. It's considered when the compression of both ulnar and the radial and the hand color returns to normal within 10 seconds after the radial delay. The apex pulse deficit, how do you measure it, is a common question. So you will say, sir, ek aadmi pulse, one person will auscultate and count the pulse simultaneously, and one other person will measure the heart rate. But that would not be possible in exam. You're not allowed to be participating with somebody else or even in practice. So what you need to do is you count the pulses that are not felt, but the heart sounds that are audible. So simultaneously, you put a stethoscope and you put your fingers on the radial pulsation. Don't count both the rates. You just count the sounds that are audible at the heart but not felt at the pulse level. So sounds audible at heart but pulse is not felt is all you count for a minute. If these are more than 10 in a minute, that suggests AFib, while less than 10 would suggest premature beat. The characteristic is what is most oftenly asked. And as I said, force, volume, tension, etc., or the condition of arterial wall, all clubbed together into would be described what is called as characteristic of a pulse. Now, how to remember various types of pulse? There are anacrotic, parvasis tardus, pulsus cellar, pulsus magnus. So there are various names that are given for various characteristics, but the classical waves that are pulse forms that are known are easily remembered by ABCD. So that's what I do. This is what we have already discussed, the waveforms that we'll find. So this is a very busy slide. I have covered most of the important pulse characteristics, and Dr. Mohit had asked me that Dr. Kamal do take their hemodynamic equivalents.
Yeah.
So for every pulse characteristic, there is a hemodynamic correlate in your valvular case that you are supposed to be talking about. So anacrotic pulse, so ABCD, what do I mean by ABC? A for anacrotic, B for Bispherian, C for Corrigan, D for dicrotic. Easy to remember. These four, if you are fumbling in exam, just remember ABCD, and then the rest is just, you'll buy time for alternans, paradoxus, parvasis tardus, salar tardus, etc. A for anacrotic means aortic stenosis. Once you can perceive an anacrotic wave, it's said that probably the gradient across the aortic valve is more than 70 millimeters of mercury, which means it's a severe aortic stenosis. Bispherian pulse, we'll discuss each of them separately. So in anacrotic pulse, you are predominantly feeling the anacrotic wave. So perceivable anacrotic wave, which should be more than 25% of the peak of the aortic of the tidal wave. That's only when you'll be appreciate anacrotic wave separately from the tidal wave. Otherwise, the percussion and tidal, as I said, would merge into a single waveform, and you'll not be able to feel only one systolic and one diastolic is what sometimes dicrotic may be perceived. Bispherian pulse is, as you know, the common cause may be asked is moderate AS, then severe AR and HOCM, and then you will be asked how the two differ. And one modern cause you should know is EVAR or TEVAR. Once you've done a patient, put on an EVAR and a TEVAR, if you'll search literature, they mention the patients who've been undergoing EVAR or TEVAR, the endovascular repair of the aneurysm. These patients can also present with a Bispherian pulse, and I'll discuss the mechanisms as I proceed ahead. Watson described what is called as the water hammer. Also, that's how the name came. But before Watson's description, it was Corrigan who had described this in characteristic detail, and that's how it's called as water hammer pulse. Water hammer word comes from a Greek toy, which was filled with vacuum on one side and the water on the other. And when you rotate the toy upside down, it would fall with a thud because of the vacuum. And this characteristic would give rise to what is called as water hammer. So water hammer is a Greek toy which was used in the Greek mythology and has been described in the literature based on it. And it's basically nothing but pulsus cellar and pulsus magnus combined. So basically, though people talk about it as a rapid distal runoff, that there is a washout of the flow, and that's why the mechanism, people raise the hand of the patient so that there is emptying of the blood. I'll again come to that. Also, this was the previous theory, again proved incorrect. It doesn't hold true. There is a new wave which is described called a suction wave, which is responsible for what is called as Corrigan's pulse or water hammer pulse. purely because it's a systolic phenomena. And this has been analyzed and described by pulse wave intensity analysis by Korea's papers, which I have mentioned the reference also downstairs in the 2018 literature. And this is, some people talk that it's the pulse pressure upon systolic blood pressure is usually more than 0.5 when you would start appreciating a water hammer characteristic. Dichrotic pulse is when you perceive the dichrotic wave prominently. Again, some people say it should be more than 50% of the percussion wave to be appreciated. So dichrotic node should be more than 50% of pulse pressure to be perceived as a separate waveform. It's found in state of shock. But if you feel the second waveform and systolic blood pressure is more than 130, then this is not dichrotic pulse. If you're feeling a twice beating pulse, a pulse which is beating twice. So there are three pulses which are twice beating pulses: anachrotic pulse, Bispherian pulse, and dichrotic pulse, all three. Only dichrotic is one which has got one pulse in systole, one pulse is diastole when you're auscultating simultaneously for the first and second heart sound. So the twice beating pulse, if you're finding, and the systolic blood pressure is more than 130, it can be anachrotic or Bispherian, but it cannot be dichrotic. That's the other hemodynamic equivalent of dichrotic pulse. Pulsus parvus it tardus again occurs. It's a slow, late peaking pulse. That is parvus it tardus, and it's again found in severe AS. And usually it represents aortic valve area less than 1 centimeter square, which means again it's a critical AS. Pulsus alternans, where one pulse is strong, the other pulse is weak. It's usually found in patients with dilated cardiomyopathy if the LV function, systolic function, is less than 30%. But again, this is anecdotal, not many literature to support it. It's also found in patients with AS with LV dysfunction and congestive heart failure. So remember, aortic stenosis can present with variety of pulses. Anachrotic pulse, pulsus parvus et tardus, pulsus alternans when LV dysfunction, and Bispherians if you have associated AR. Pulsus paradoxes. The paradox, so people call, what is paradox in pulsus paradoxes? The paradox was first described by Kamal, and he said the paradox was that though the patient was breathing normally, but his pulse was disappearing. The paradox was not the fall, and so people call it pseudo paradox, etc. That's not the case. It's correct that it's the exaggeration of inspiratory fall in blood pressure, but this is primarily because of the pericardial fluid, which is compressing on the RA predominantly and not allowing the venous return to be compensated by the intrathoracic pressure by inspiration or expiration. But this exaggeration, usually, which is normally present up to 3 to 10 millimeters of mercury, going beyond 10 would make it apparent. Classically, it is said that it would be palpable pulsus paradoxes if the drop is more than 20 systolic. It would be recordable between 10 to 20. More than 20 pressure fall would be a pulsus paradoxes when you call it palpable, not recordable. So 10 to 20 recordable, more than 20 palpable. So that you find in patients with pericardial effusion, primarily cardiac tamponade, and it can also, however, occur in severe obesity or patients say in obstructive sleep apnea. In COPD also, you can have pseudo paradoxes, just the opposite actually. And in the patients with positive intrapulmonary pressure when they are generating on ventilator, they can have a reverse paradoxes, because the positive intrathoracic pressure is now increasing the pressure rather than decreasing the pressure. Pulsus cellar you find in AR, and pulsus pure tardus rather than parvus et tardus can also be found in aortic stenosis. So very busy slide, as I said, but that summarizes various pulse characteristics with hemodynamic correlates. Water ML now, coming to the old theories and what we still are asked in the exam, and then you can be, if the examiner is updated in the theories that have been experimentally proven to be incorrect, you would find out that the water pulse is correct. Water hammer is characterized by rapid upstroke and sharp descent, which is typical of chronic AR. However, the mechanism that people talk about, like Corrigan once described it, is a sudden fall in diastolic pressure, resulting in the arterial emptying in diastole due to regurgitation. But as has been pointed out by sphygmomanometer also, the water hammer is purely a systolic event. So nobody is talking, why should there be a diastolic fall of the runoff of the blood? So it doesn't prove. So water hammer is a systolic phenomena. Diastolic emptying or raising of the hand or blood running away in diastole does not hold true, because it's purely, as we documented, a purely systolic phenomena. Hence, they did a what is called wave impact analysis. So this is again in 2018 a very important paper published, the reference which I quoted. They looked at a patient who had a bisvariance recorded due to abnormal forward, what is called a suction wave in mid-systole, which follows a normal forward compression wave generated by ventricular contraction. So the radial pulse showed water hammer configuration with a sharp upstroke and downstroke. And the wave impact analysis showed that the mid-systolic expansion was transmitted from the central circulation to the radial artery, responsible for sudden radial pressure descent after initial peak, what resulted in water hammer configuration. So you can look at the pressure drop occurring well within the systole. And the red areas which you see here, the negative wave intensities, are primarily the reflected wave which are coming from the carotid, and the radial wave intensity from the head and the hand respectively. So the whole of the event is actually systolic event. There is nothing to rapid distal runoff being responsible for causing a water hammer or emptying. So raising hand, may not raising a hand, both can actually accentuate and bring out a water hammer when you're looking at the wave intensity analysis in these patients. So though carotid art, so again you'll be asked which pulse to palpate where. So carotid is most suitable for evaluating arterial pulse because it's near to the aortic valve. If it's not available, then you go to brachial. A more peripheral like radial is more suitable when you're looking at a collapsing pulse or diacrotic pulse. So diacrotic and pulsus paradoxus, you can even palpate in the femoral arteries. These waves are exaggerated as pulse wave is transmitted to the periphery. Pulsus paradoxus is best in femoral, as patients with tamponade usually have low pulse volumes and they have elevated JVP, which can interfere with the carotid pulsation itself. So this is how the bisvariants differ. This is how the bisvariant looks like when you're asked to draw. So bisvariance in Latin means twice beating. Pulse is a waveform of two positive waves, both coming in systole. Wave is upstroke and rises rapidly and forcefully, producing the first systolic percussion wave, and then there is a brief decline. And there is another somewhat slowly rising pulse wave, which is called as a tidal wave. So bisvariance is then asked that how does a bisvariant of AS with AR differ from, say, so it's adds to moderate AS, severe AR. So there is a high amount of blood with some amount of obstruction causing two separate waveforms. So abnormality of the LV ejection and reflected wave from the peripheral arteries will contribute to the occurrence of second wave. The bisvariance is sometimes more easily palpable in brachial and radial, and it often occurs in patients with pure AR also when there is some amount of LV dysfunction. But usually it's, as I said, moderate AS with severe AR, and there is association of hence a rapid ejection of increased blood flow, like in exercise and PDA also. There have been papers about pure patent ductus arteriosus presenting with pulsus bisvariance. So even bisvariance may be present not just only in these two conditions, which we classically know, AS with AR and HOCM. It can be present in post-TAVR. It can also be present in patients with PDA or even in hyperdynamic state with ASD, with A or moderate AS. The common question that they may be asked is, how does the HOCM bisvariance differ from AS with AR? One, in bisvariance, it is recordable, not palpable. That is number one. But when you say the mid-systolic negative waveform, usually that coincides with the marked decrease in the rate of contraction. So what is called as spike and dome pattern. So HOCM is spike and dome pattern. ASAR is not spike and dome, but actually truly bifid, two wave flows, two waves that are perceived. And the second systolic or tidal wave most likely is produced by the reflected waves, and bisvariance can hence be elicited or changed. You can have a bisvariance not present and then improved or decreased by dynamic auscultation. So you decrease the LV size, increase its contractility, you can actually bring out a bisvariance. Pulsus parvus tardus is a slow rising, late peaking pulse. So patient with moderate to severe AS with arterial pulse that is small, delayed systolic peak, and detectable shoulder on the upstroke, which is the anacrotic pulse, and easier to detect in carotid rather than periphery is pulsus parvus tardus. Most middle-aged patients with uncomplicated AS have parvus tardus, but this pulse can occur even in mild stenosis. So this is not specific. Remember, in patients who have got stiff peripheral vessels and they have arteriosclerosis, even in patients with mild or moderate AS, you can get parvus tardus. And apparently normal pulse is, arterial pulse is again not unusual in severe AS who have great decreased distensibility of greater arteries. So it can be either ways. You can have, so hemodynamic correlates, though I mentioned, this is classically believed. It does not always go with them. It will, lot of it would depend on the arterial compliance, hemodynamic capacity or of the vascular compliance, and severe LV failure often results in small weak pulse that can be difficult to distinguish in AS. Dicrotic means double beating again, pulses twice beating, one in systole, one in diastole. As you can see, this is the second dicrotic notch which has become prominent. As I mentioned, it should be 50% of the height amplitude to be perceived usually. But again, it all depends where you're palpating, how you're palpating, what are the pressures between the limb. And the dicrotic pulse usually signifies a poor prognosis. But one condition where it signifies good prognosis is when your intra-aortic balloon pump is working well. So if it's well synchronized with the diastole, that's how it's supposed to be timed. That should be inflating in diastole. If you start getting dicrotic pulse after putting in IBP, that's the evaluation of simple looking at pulse if your IBP is working well or not, apart from looking at the screen, whether the augmentation of blood pressure is adequate or not. So it's the most common, again, physiologically in young and middle-aged patients, if they have impaired LV function, the usually associated low cardiac output state or diminished stroke volume with LV and diastolic pressure being raised and high systemic arterial resistance. So the hemodynamic correlate of dicrotic pulse, apart from it ruling out systolic motion more than 130, more than 50% of the amplitude, is low stroke volume, LV-EDP elevated, and increased SVR. Rarely it can be palpated in young febrile patients, as I mentioned, in enteric fever also. So major abnormalities in these patients include a short systolic ejection time, low dicrotic notch, large diastolic wave, narrow pulse pressure, diminished rate of price pulse, and lack of distinctive percussion and tidal wave. Hyperkinetic pulse is again described in exercise or fever. This would usually go in patients with mitral regurgitation, also in patients with patent ductus arteriosus and AV fistula. The cardiovascular disease associated with stroke volume being increased and large stroke volumes being present, and even in patients with chronic hemodialysis can have hyperdynamic pulse because of the fistula, anemia, hypertension itself. But this is different because the diastolics are not so low. You have a big stroke volume, you have high systolics. The diastolics are not very low. Hypokinetic pulse is nothing but small weak pulse present in this diminished stroke volume. Decreased stroke volume is associated with, again, decreased rate, duration of LVET, and a narrow pulse pressure despite increased arterial resistance. So common causes are hypovolemia, LVAF, mitral or aortic stenosis. Pulsus paradoxus, as I mentioned, 20 more than above is palpable and detectable. Milder form will be demonstrated by sphygmomanometer. Sometimes you may be asked, how do you demonstrate or how do you record pulsus paradoxus? So the technique is to inflate the BP cuff above the systolic, then start deflating till you get the corticoff sounds only during expiration, but not they disappear because of the fall during inspiration. So patient is tachypneic, you're feeling and the corticoff sounds are perceived only during either the expiratory phase, and inspiration it is disappearing, and then you keep lowering till you actually now feel the corticoff sounds both in both the phases, inspiration and expiration. The difference between these two phases would be more than 20 millimeters, or more than 10 would be called as pulsus paradoxus recordable, and palpable. If you can see, then it is pulsus paradoxus. So it's common with tamponade. Fluid accumulation causes the intra-pericardial pressures to rise, the filling capacity being reduced, and during inspiration, the expected augmentation of venous return to the right side would be hampered. The diminished thoracic pressure can cause a pooling of blood in pulmonary veins and capillary, and diminishing the pulmonary venous return to the left atrium. So this is how, as I said, you would inflate. The conditions, however, where the pulsus paradoxus, this is another commonly entrance test question, in which condition the pulsus paradoxus is absent despite tamponade. So whichever other way the ventricle can fill up. So the other way the ventricle can fill up is the shunts inside the heart, which is the ASD, VSD, or aortic regurgitation. So if they are alternate means of the ventricle to fill up on the right side, from the ASD, VSD, or AR, the pulsus paradoxus will not be present now because of the compensation of the volumes by the respiratory changes inside the hemodynamic. So different hemodynamic mechanisms, they contribute to the pulsus paradoxus. It can be in certain patients with SVC obstruction, asthma, obstructive pulmonary disease, in patients with pulmonary embolism, shock, post-thoracotomy. All these patients can also sometimes present in pulsus paradoxus. Thank you very much for patient hearing, and it's too glad to be always be with CSI Delhi chapter. And I'm thankful to Dr. Mohit and the team for allowing me to present this. Thank you very much.
Thank you, Kamal, for an elaborate lecture. So now it is open for discussion. If there are any questions or comments, Dr. Girish, Dr. Sumodh.
Yeah, it was a lot of material Dr. Kamal has covered in a short time. So, Dr. Kamal, how do you recommend if no, the student is asked for the mechanism of collapsing pulse in 2 sentences, 3 sentences? How should you explain?
So it should be mentioned as I think the key word should be suction wave. What is suction wave is basically nothing but the rate of change of the flow from the beginning of systole to the later part of the systole. So the elastic compliance, or the way they have done WIA, which is the wave intensity analysis, it is the intensity of the flow which determines the characteristic to be in the initial part of systole and the later part of the systole. Most of the blood is being gushed through in the initial part of systole, giving rise to the rapid upstroke, and the later part, because of the low peripheral vascular resistance, as you may call, or what is called as rapid distal runoff, the older theory, is allowing the second part of the blood to drop out quickly. So it's not that the blood is returning back. Most of the blood is going forward because of the low SVR in the first part of systole. So there is not much left to go in the second part, is what is giving rise to the negative wave. So they have described in the paper that I shared as a reference, they have described it as a suction wave, and they have demonstrated in that paper how a single patient of aortic regurgitation could have both because of this suction wave. So the difference between the Corrigan's pulse, the water hammer pulse, and Bispherians actually is nothing but the spectrum of the suction wave into 2 separate entities, how you perceive in a single patient. So they have demonstrated in a patient of AR both being recorded, palpable, and defined by pulse intensity analysis. So it's the key word they have described is suction wave. If somebody says suction wave, I think he's talking about the same article, which is the first article to reference be talking about. And the same group has then done a lot of analysis on all kinds of pulses. So wave intensity analysis is a fantastic new
but Kamal, my question, you've given a very elaborate or is to be your knowledgeable or a professional answers. So if I am to say that, as Sumodh put it, that how will a resident put it in 2 or 3 lines for to satisfy an examiner? So goes to lines.
So he should talk about, because the water hammer pulse is because most of the forward outflow is happening in the initial part of systole with nothing left to pump in the later part of systole. It's not a diastolic event. That's what the keyword is. Because the older theory was कि वो पहले आगे जाता है फिर वो reverse आता है. When you raise the hand, the blood goes back into the heart. That's not at all true. That is not something that is acceptable at DM level. We have to say most of the blood is emptied in the initial part of systole with nothing left to eject in the later part of systole or in diastole. And this differential aspect gives rise to what is called as water hammer pulse.
Now, one thing I understood your question, and I understood what Sumodh also was asking about. Now, the resident should be careful enough to correlate his description with blood pressure also. That is very important. If he says there is a collapsing pulse and he says a systolic blood pressure of 100, 110, so then that becomes a issue, right?
True.
And number 2, again in the same breath, what Kamal was trying to explain is, if the elasticity is lost,
correct,
because of thickening of vessel wall,
true,
you will probably lose the character of collapsing.
Completely agree.
Right. So be it in a degenerative AR with a thickened vessel wall, you will probably not have a collapsing pulse. Number 1.
Agreed.
If it is entirely because of systolic event, then the same author should be doing another experiment in isolated systolic hypertension, where blood pressure is of around 200 and diastolic of 80, with a pulse pressure of 120 or 140. Still, they don't have that character of collapsing, right? So yes, he has a point in saying that the most of the event is probably systolic, with elasticity of the artery being intact, and to some extent diastolic forward backflow also, which gets augmented by just raising your hand. That's AR. As such, there is the direction of flow in diastole would be towards or centrifugally towards the heart. And once you elevate the limb, probably it is going to get augmented. That's all. But the student has to be very carefully, analyze his findings also. He has to see whenever he is talking about collapsing pulse, he has to, see blood pressure where pulse pressure should be more than 60 and diastolic pressure should be less than 60. Only then you are going to get the character of collapsing pulse. Otherwise, would not.
True. So one point also that was mentioned in some of the articles, what was the 50% rule. So as you correctly mentioned that the 60 of pulse and 60 of diastole, both are important. But the pulse pressure they mentioned should be more than 50% of the systolic, which again, I mean, if you have 100 systolic, you can't have 50% would be, 100 by 50. Again, it's very dicey. It's still 50%, but your point is very valid. Would this patient come with water hammer? Probably no. So even if you have 100 by 50, it's 50% of the systole. The pulse pressure is already 50, but you will not get. That's correct. I think there are some more pulse pressure things like proportional pulse pressure. I think I could have touched upon, I deliberately skipped upon that. The proportional pulse pressure as a reflection of cardiac index. The augmentation index, which is again another characteristic, but I think it's part of the overlap of blood pressure and pulse. And because I was talking only about the pulse, I tried to skip upon it. There are other parameters of calculating cardiac power, again, which is determined primarily based on the mean arterial pressure. But these I thought were part of the blood pressure evaluation rather than pulse evaluation. So I've skipped upon that, but those are some other important topics. I think cardiac power is very important now with the era of Impella and ECMO coming in. I think every student must know what you mean by cardiac power index and how do you calculate it. What is the formula for cardiac power index? 451 into MAP divided by CO. That's the formula, 451 multiplied by mean arterial pressure divided by cardiac output, if I'm correct. So unless these will reflect which patient is requiring what kind of device. 0.6 is something which is very bad. Or 1 is what you expect in a normal heart. If it's below between 0.7 to 0.9, you would 0.8 to 0.9, you would put an IBP. Between 0.7 to 0.8, Impella or ECMO would do. Below 0.6, if you go probably ECMO, nothing else would work. Below 0.5, usually the mortality is very high. I think those again, but I thought to skip them because of this lack of time, and maybe I thought I would be deviating from the topic.
Yeah, even traditionally, when we explain the mechanism of experience in pure air, in severe air alone without AS. Again, we generally say the initial ejection causes a pressure on the vessel wall, and then there is elastic recoil, which is responsible. Is that the same as the suction wave that is mentioned, that recoiling?
Yes,
it is the same.
Yes,
I think there is
yes, Dr. Sumo. That's what the authors have tried to focus. It's a very interesting article. I'll try to share the article individually with you. But it's a very interesting article how this author and this subgroup of people have analyzed waveforms versus the pressure changes and their perceptions. And this is what they are talking about. They are very right in the sense that water hammer, I completely agree. In severe AR, what Dr. Girish was saying, when you raise the hand, the blood is going to come back. It's AR. There is no doubt about it. It's going to get augmented. Nobody is countering that. But the water hammer characteristic is purely systolic event. Though the reversal is there, then if the reversal is diastolic, why should that be responsible for a characteristic of a pulse which is felt only in systole? Diastolic event should not reflect the systolic event. That's what they are talking about. And for that reason, they are mentioning what you, Dr. Sumod, was clearly trying to point out.
Then one more question which some student has asked is about a measurement technique in atrial fibrillation, BP measurement technique.
Right. So this is again an important question that they ask as to how do you measure blood pressure in atrial fibrillation. The techniques that have been described are separate for systolic and diastolic. For the systolic is the one that when you get the first Kortokov sound, that's very easy. But for the diastolic pressure, because the AFib is going to have different variable cardiac output coming in with each cycle, you may have some cycles not getting opening up the aortic valve at all, while some would be opening it at much bigger force depending on the latency period between the previous cycle and the subsequent cycle which is contracted. So the Kortokov sounds, when it is transmitted the most, is counted as the diastolic pressure, not the disappearance. That is the common answer that one should remember. That the diastolic pressure is the pressure where the most of the Korsakoff sounds get transmitted rather than muffling or disappearance of the sound in AFib. So diastolic pressure is the controversy. Systolic is the appearance of the sound. There is not much of a controversy on that.
There are actually 2 or 3 things to this question. This is one of the perspectives. Probably the student also is wanting to ask 3 things. One is when you measure blood pressure in atrial fibrillation, number one, which instrument one should be using? Number one, that is very important. So there are very clear guidelines that whether oscillometric or aneroid, which should be used. There are very clear, beautiful articles. So you should be very clear there are guidelines that which one should be used. Second, how many readings should be taken? That is another dilemma. Should be taken 3, 5, 7, or 10 or average. So as Dr. Kamal is saying, you have to average 3 readings. That is very important. Fourth, it's a systolic one that is more prominent, that is driving the situation. So these are the 3 aspects. I will, as you have very rightly put, I think, who is this doctor? Dr. Aditya is asking. So we will put this article in a group. Just remind me, mail me. And there's a very beautiful, only 3-page article, which clears all the doubts about the atrial fibrillation. But let me tell you, measurement of blood pressure in atrial fibrillation can really land you in trouble in exam if you don't answer the questions.
But
the exam will take you.
Mohit, actually,
Yeah.
I think this is an overrated question, to be very frank.
Yeah, overrated.
Why I'll tell you. But
I completely agree. I think if we have
read
to
Brownwald now,
yeah,
the Brownwald says the same technique, that is 5 minutes apart, 3 readings. As for the normal BP also. So how did that differ for AF? So there is no difference. Again, the thing is probably you have to make the patient more comfortable. Once he's made comfortable, if the heart, I personally feel, if the heart rate is or ventricular response is less than 100, the usual way what you do for a normal person should be sufficient. Problem occurs only when the ventricular response is
in AF with fast we are the issue as I
yeah. Otherwise, there won't be much of issue in blood pressure. Even then, I think Mohit, it is worthwhile reading that article which you have mentioned. I think we can all go through it. You're muted, Mohit. You're muted.
Yeah, I agree. I think Dr. Mohit's point was very valid about the oscillometry method. You should not be using it, number one.
Yes, that is very
that is very clear. You cannot use automated instrument. You'll have to go by sphygmomanometer, gradually lower it. Wahi technique. So this is very important.
Aneroid also is fine.
Yeah.
Yeah,
again, is it not, Kamal, see, the RR, whenever it varies, is it not varying the stroke volume, which again is a determinant on systolic one?
It would.
Which should be a determinant on systolic rather than diastolic?
True. That's the reason that it actually should be varying the, see, actually when we do in the cath, when we look in AFib, every pulse has a different value for both systolic and diastolic. When you're cathing a patient, say of balloon mitral valvotomy or whatever, when you look in AFib, even their systolic varies, so does their diastolic beat to beat variability. So I think all these, as you're mentioning, is overhyped and over evaluated and over conceptualized and, rather than simplified, more complicated. But I think simple way would be, as you mentioned, if in a patient with a controlled heart rate, it shouldn't bother what instrument, what technique. If somebody comes with AF with a heart rate of 70, 80, I think the pressures would still be the same as you would have in patient with sinus rhythm. It shouldn't be a problem.
So I think if there are no more questions. Okay, Kamal, thank you so much. Again, you see, pulse is a very interesting topic. One can read from various books. There's a postgraduate cardiology, then you have your Abrahams, all the routines. You must read it from all the places, the name pulses, different signs, what are the ways you are going to elicit the responses, about the Hill signs. All these things are, there are various, there's a tree of questions which you can just spring from whatever topic you search. You touch any aspect of pulse, an examiner will be firing with all the questions. So the purpose of this particular lecture is to complement the earlier lectures also, and probably when you are able to listen, you will be able to actually make your own notes and have a very clear vision about what pulse is all about and what are the commonly asked questions in exams. So I'll be sharing, as promised, these articles also on atrial fibrillation and pulse. And I also thank Kamal, our dear friend, and my colleagues, Dr. Sumod and Dr. Girish, for this beautiful session, interactive session. And next week is the National CSI. So we would break for 1 week, but let me tell you, after National CSI, we have a good Pandora box of wonderful lectures that we have fixed up for you. most of the some of the best speakers. We have Dr. Ramakrishnan who will be joining us. We have Dr. Balachandar who has kindly agreed. Many other people who have agreed for various spectrum field touching pulmonary arterial hypertension, and we'll soon be starting with case discussions also. Obviously, we'll be disturbing our dear friend Kamal for the clinical case discussions, which is a wonderful part of our exam. So
it's always a pleasure. Not at all.
Thank you so much everyone for joining this journey, and thank you especially all our fellows. Please encourage all your friends to join this group. It's pure academics. Please encourage even your MD residents to join this group so that able to get the feel of what this basic cardiology, clinical cardiology is all about. Again, message us personally so that we can post all the links to you in case you have any questions and comments. Repeatedly, I'm saying, because I'm getting repeated requests and there is some disconnect that is happening. Thank you, Intas, for providing us this platform. So after the break of next week, we'll catch up again for another wonderful lecture on clinical PG track program by Delhi CSI. Have a safe weekend. Have a couple of safe weeks, and goodbye. Good evening.
Bye-bye. Thank you. Bye-bye.